To what extent is a child's mental health set in pregnancy? What can women do in pregnancy to ensure optimal mental health for their child? Also, what happens to women's brains and mental health when their nutrition is suboptimal in pregnancy? How can we help children and teenagers to achieve their full potential for mental health? My next guest is Julia Rucklidge, who is Professor of Clinical Psychology in the Department of Psychology and the Director of the Mental Health and Nutrition Research Group at the University of Canterbury in New Zealand. Julia, welcome to my podcast.
Oh, thank you for having me, Patrick.
Before we dive into your amazing research and our topic for today, what got you started anyway in doing this research into mental health, psychology, and nutrition? I mean, your background is not nutrition as such.
Correct. Yes. Okay. So I did my PhD in what I'd call conventional psychology or clinical psychology program. And I'm sure you understand that if it's conventional, that means that nutrition wasn't touched on at all as part of the understanding of why people have psychiatric disorders. That was in the 1990s, although to be honest, things really haven't changed in those training programs or from physicians for or other mental health professionals. But to give you the context, so doing this training. I am doing a PhD on what it looks like. What are the psychological difficulties that women with ADHD have? So that was what my PhD was on. So not anything to do with nutrition. But when I was doing my PhD in Calgary, my PhD supervisor, Bonnie Kaplan, I think we have this kind of thing of where mentors really have played a huge role in our lives and where we've gone. And that's certainly true for me. And I think that's also true for you as well. Um, so Bonnie got approached by some families from Southern Alberta, Canada. And what was um, interesting about those families was that they were, first of all, very large families, like lots of children. They were from a small Mormon community, and many of them had psychiatric disorders. So, bipolar disorder, psychosis, depression, these really challenging things that can really destabilize people for their entire lives. Uh, what happened was that there were two men, Tony Stephan and David Hardy, and Tony married into a family where there was severe mental health problems, and his wife committed suicide, and her father had committed suicide, and then he has kids who have the same condition, who are in and out of hospitals, taking their medications and not getting well. And so he happens to talk to David Hardy at a church function, and David says, well, I don't know about what you're describing your kids, but it sounds a little bit what we see in animals, in pigs, is that when they get really undernourished, they start biting each other. They get what's called tail and ear biting syndrome. And the way we solve that is by giving a broad spectrum of micronutrients, and then all of that irritability goes away. So Tony thinks I have nothing to lose. The meds aren't working. They're just in and out of hospital care. And so they give this a go. And they find that by giving these kids the micronutrients, not only were they able to reduce and eliminate the medications, but they got well for the first time in their lives. So they start uh, testing this concept out with other family members, and they find the same thing, and people are starting to get well. And so they decided that they wanted to get it studied. And so hence they started to approach scientists in Alberta to see whether or not there was anybody who was willing to do the studies. And so one of those scientists was Bonnie Kaplan. Um, so she ended up initially telling them to take their snake oil away, and she wasn't interested. But they sent her data, and she was intrigued by the data that they shared and showing bipolar disorder and the symptoms going into remission. So she decided to do a very small study, and I was around at the time, going, "What is happening? Why has Bonnie suddenly moved away from the traditional kind of research and started to dabble into this?" Um, and she told me these stories of remarkable recovery. I then sorry, it's a long story, but, I had been taught that nutrition was irrelevant to brain health, and to hear these studies, these stories of people getting well, uh, it sparked a curiosity in me that, has never left, and I always try to instill that in my students as well, which is that when an idea contravenes current way of thinking, don't reject it. Embrace it. Be curious. Apply the scientific method to it and see whether or not there's any legitimacy to it. You can either prove that it's wrong or you can prove that it isn't wrong, but don't immediately reject it just because it challenges the worldview.
Your
So
story is,
I,
we have a lot of parallels because I met Bonnie actually in the 80s, and I, like
oh,
you,
no way.
yeah,
Okay.
I was studying experimental psychology and focusing on schizophrenia. And we were taught it's got to be randomized placebo-controlled trials. And there was one I found that had extremely good results. And I took it to my professor and said, "What about this?" It was Dr. Abram Hoffer, who was the head of psychiatric research in
Hmm.
Saskatchewan. And
Yep.
it was actually, I didn't know it at the time, the first ever double-blind controlled trial in the history of psychiatry.
Hmm.
And he sort of, he couldn't really explain it. He's, oh, some crazy theory about nutrition or something. So I jumped on a plane and met him, and said, what's your success rate? How many people have you treated? He said about 3,000. And I said, what's your success rate? And he said 85% cured. And I said, you've got to explain that because I've never seen a cured schizophrenic. What do you mean by cure? And he said, free of symptoms, able to socialize with family and friends and paying income tax. So I said,
Right.
I want to meet some of these formerly schizophrenic people, and I did. And then I said, I want to be your student. So that was kind of in the 80s. And
Mhm.
off the back of that, when we started the Institute for Optimum Nutrition, and it was actually Dr. Abram Hoffer's command to me, in effect, to start the charity Food for the Brain. And,
Mm.
and one of my first students at the Institute for Optimum Nutrition, which we started with Linus Pauling as patron, was a schoolmaster, and every student had to do a project. And we were talking about doing a multi-nutrient for IQ study, and we did a
Right.
pilot, and it worked. And then we thought, it's going to be very controversial. Let's get a real skeptic to run it. Professor David Benton at Swansea was
Yeah,
very,
and he was converted.
yeah, it
He's
was
been doing
very
nutrition research ever since.
exactly. And so multi-nutrients. But let's get into your current research because our last,
Yes, I know because this could last forever. So I just to cut the rest of the story, I
yeah,
moved away. I went to Toronto and then I came to New Zealand and I decided to study the idea just because I could either show that it didn't work or it could work. But by then I had lost that naive assumption that young students have, which is that our current treatments are working,
yeah,
realizing very quickly that they're not, and not enough people are getting well. And so I thought, what do we have to lose to look at the impact of these nutrients on people who are struggling with mental health challenges?
yeah.
So hence I started and I never looked back, and I've been doing those randomized controlled trials, not because I love them, but because that that's hopefully what might get attention. I'm not convinced, though, that's true anymore. But
Well,
anyway, had to probably discover that.
we can talk about that at the end. But our
Yeah.
last guest, Professor Michael Crawford, he made it clear that suboptimum nutrition literally shrinks the brains of women. And there have been some very big studies recently which have said that literally brain size in the majority of pregnant women shrink without necessarily saying why. And Michael
Mm,
Crawford's work also showed us that you can kind of predict which children are going to get neurodevelopmental problems. And one sort of obvious thing is that, a pregnant woman is building a baby. Uh,
mm,
so, they're feeding two people. So in effect, they've
mhm,
got, maybe double the demand in relation to certain nutrients. And the brain, of course, is growing so rapidly during pregnancy. So
mm,
in other words, you shouldn't just have the same intake of nutrients. Theoretically, the intake should be much, much higher. And yet there is really very little advice, honestly,
I'd
given
agree.
pregnant women about increasing the intake of nutrients. And do you think there is a lack of advice given? And is the given advice correct?
I absolutely think there's a lack of advice given. I think most of what women experience, at least I can speak to this having had two children, is fear of what's going to harm your kid. And so you hear about how if you eat fish, I mean this has been hopefully changed a little bit by Joe Hibeln and proving that fish is actually safe and you need to eat fish during pregnancy. But for a long time, women were scared of eating fish because of fear of mercury contamination. And what's been shown very clearly is that you really need those fats, the omega-3 fatty acids particularly, but I'm sure a lot of other of the nutrients as well. So there's a lot of fear-driven approach around things that are going to harm you, like the salad bar or, sushi or, you name it, it's you're scared. And I think what the result of that is that the foods that are supposedly that look safe are ultra-processed foods. So I wonder what's one thing that's happened is that they have been seen as being things that are safe for women to eat, and they're eating a lot of it. And so we know that globally there's an increase in the consumption of ultra processed foods, but I know that in pregnancy there's also data that's showing that women are consuming a lot of those foods, and that's having a detrimental effect on their offspring and their own health. But that's one of my thoughts is that I think that this fear is instilled in women. There's also the if you even wanted to look at the dietary guidelines, I mean, you and I could talk a lot about dietary guidelines, uh, I'm sure, and the pitfalls and the problems with it. But the dietary guidelines are about the macronutrients, your carbs, your fats, your proteins, and there's very little conversation around those micronutrients. If you look at food labeling, it's all about it's low in fat or it's low in sugar, but you don't hear about those micronutrients, the vitamins and minerals that are so essential for brain development, brain health, brain functioning. It's just not part of that conversation. And I mean, it's probably partially driven by the food industry that doesn't want us to have that conversation because ultra processed foods are so low in those essential nutrients.
Now
I don't
there
know if
is,
I've touched on some of the reasons why I think that the
yeah.
guidelines or what women are eating are is so poor.
Well, yeah, and also it's not just guidelines; it's whether people actually do it. And
There's that too.
there is a general understanding that the guidelines are that pregnant women should have some folic acid supplementation, maybe
Yes.
some iron, and so on. But do you have any idea on the ballpark of how many pregnant women do actually supplement because they're
That
pregnant?
that is that is a good question. And I mean that's certainly been a push in New Zealand is to get them to take folic acid during the first trimester. And I don't think I think they hit around 80%. Do you know?
No, I don't know, is the honest answer.
Okay.
And in some countries, but they're doing folic acid fortification, to address
Yes,
that kind of thing. I think folic acid
exactly.
and iron are probably the two most conceived. Zinc, for example, we'll talk about later.
Yeah.
Very good to talk
Or
about it.
in New Zealand, it's iodine. And so iodine is the only nutrient
Yeah.
that is recommended
Oh.
post the first trimester
Mm.
in New Zealand. And I just think, why? Like, I mean, you and I were having this conversation earlier around the single nutrients and the focus on single nutrients. But why have we, as the population, or why do we focus so much on these single nutrients? I mean, we know that the research shows that a multi-nutrient does better than folic acid by itself in
Yeah.
terms of reducing um, spinal bifida. And yet we seem to ignore those studies and continue to just recommend that one single nutrient.
Well, let's get
It's the
into
same
your
thing in so
get
much
into
areas.
your research and what you're actually
Sure.
finding, and then we can kind of kick those ideas around because your recent research has focused on a nutritional approach to depression during pregnancy.
Yes.
And before we look into the results of your study, how common is depression in pregnancy and is it on the increase? And do you have any idea why, if that's the case?
Yeah. The numbers are about 21% globally of women struggle with depression during pregnancy. It's not the easiest number to get at, as I'm sure you can appreciate, but that's the number that seems to be pretty standard in different countries where they have assessed it. There's data that shows that it has increased during the COVID years, and so that those numbers have been rising by a few percent. Um, but we also know that when you look at any psychiatric disorder, those numbers have been increasing over the last few decades. Often the conversation is around better willingness to reach out, better diagnosticians, better, health systems and services available. I don't completely agree with that. I think there's so many things that are in our environment that have changed really rapidly that before you start to say it's because we're just getting better at it, I think we should also be looking at the environment to see whether or not there's some obvious toxic things there that might be contributing to that. And the one, of course, that we're talking about is the toxic food environment. But you could also look at social changes, or you could look at the social media, or all of those other rapid changes that have happened in our culture that could also explain why more people are struggling with mental health challenges.
And before we get into your studies and the effects in your studies from multi-nutrients, of course, the main treatment for
Yeah.
depression is
Yes.
antidepressants. Um,
Correct.
are
Or
they
psychotherapy.
or
Yeah.
psychotherapy? But I know here it's very hard to get psychotherapy. It's very easy to get antidepressants.
Yeah.
Are they widely used in pregnancy? Are there reasons to be concerned about their use in pregnancy?
Yes. Okay. So this is something that I knew very little about. Well, I know a lot about medications generally outside of pregnancy, but knew very little about its use in pregnancy. So I have scoured this literature pretty extensively over the last year, partially to respond to a lot of the critics. So that's what's led me to become quite uh, s- s- uh, upskilled in this space. So at the moment, the percentage of women who take antidepressants during pregnancy in New Zealand anyway is about 3%. That can go up to about 7% in the US. And yet we know, I think in the overall data outside of pregnancy, it's around 17, 18% of people are taking an antidepressant. You probably know the UK data. Is it around that number?
Similar, about 1 in 5 women on
Yeah, yeah,
antidepressants. Yeah.
yeah, 20%. So so it is lower in pregnancy, and that is, I believe, mostly driven by women choosing not to take them. So even though the prescribers are very clearly saying it's safe, and I'll talk about that a little bit more about the safety. They're saying it's better for the mother to get treated for her depression than to risk her getting unwell and then the consequences of the being unwell on both her and her attachment to her offspring. So the recommendation is if you're on an antidepressant, you should stay on your antidepressant during pregnancy. So that's the story. That's what's being told to moms during pregnancy, from my understanding. And I've talked to a lot of people about this. But the women are still choosing to come off of it. And that's interesting that they are making those decisions. When we look at the data, though, one of the things that I was stunned by, and this, I don't know if this surprises you, but I could not find a single randomized control trial um, uh, of using antidepressants during pregnancy versus placebo um, anywhere. So there hasn't been one done. And so it was kind of ironic to hear that they're viewed as safe from a medical model when the RCT is viewed as the gold standard, and yet there was no RCT ever done during pregnancy. And so why hasn't that ever been done? And I think I know the answer. And I think it's twofold. One of them is that there have been a lot of observational studies. Now, observational studies are challenged by the fact that there are so many confounding variables that influence outcome. And so you're looking at a whole bunch of different variables, and you're looking at, say, preterm birth, or you're looking at low birth weight, all of these indicators of um, a a good start to life, or or not so good start to life. And when they've looked at those in combination with depression and antidepressants, sometimes the antidepressants come out as being a risk factor and sometimes they don't. And the latest umbrella meta review showed that they didn't think that the antidepressants were having any detrimental effect. Now, when I look at these data, what is clear, and I've seen this in all the studies, is that the rates of, say, for example, preterm birth are higher in moms who have taken antidepressants. They are higher. But when um, you correct for her depression, her age, all those other things that may go alongside antidepressants, the antidepressant effect disappears. And that's why they're saying that the antidepressants are not harmful. So I guess I'm curious, though, about why it is that if you're not depressed in pregnancy, which you should be if you're taking an antidepressant, why is it that the effects of depression are that those risk factors of depression, which is, say, for example, increased preterm birth, why is it that the antidepressant isn't correcting that?
Hmm.
So we could say that the antidepressant aren't necessarily having a detrimental effect on preterm birth, but they're not correcting what should happen if mom isn't depressed, if that makes sense.
Yeah, they're not
Yeah.
working.
So, huh?
They're not working.
They, well, I
They're,
mean,
they're either not working or they're having a preterm issue. But
yes. And so you can't touch the side that they're having a preterm issue, is being what I've been very, very clearly told when I've been presenting this to psychiatrists, is that they're not harmful. But what I then reply with is that, but why aren't they correcting the risk factors associated with depression? Because if they're working for the depression, then surely they should have an impact on all of these other outcomes. But
yes,
they're not.
no.
So that's a very hard conversation to have. And I can appreciate the challenge that if you are a prescriber and you have been very much convincing and encouraging women to take antidepressants, and then the studies start to reveal that they might be causing harm, you really it's a very uncomfortable space to be in, and it's a really difficult one for prescribers because that what else then do they have to offer? But
Let's
I'd
get
like to say that we could offer them nutrients because we've shown they do correct the depression as well as those underlying effects on other risk factors. Or
let's get inside your study because you've
yes.
been giving multi-nutrients to pregnant
Hmm.
women with, controls, and some have
Yes.
been antidepressants, some
Yes.
haven't, so you
Yeah.
can do comparisons. So tell
Yes.
us about your study and
Sure.
tell us about the learnings from your study, the results.
Yes. Okay. So this is a complicated study. It's ended up in about, I think we're at 8 or 9 publications now. So there's a lot to it. It started simple, but it ended up getting complicated. So it started as a simple study of a randomized control trial to see whether or not we could have a positive effect on depression during pregnancy. And that was it. In the end, we tried to design it so we could look at postpartum depression, but it requires a totally different design. And in the end, we thought we can't do everything, so let's do this. And that is to give the nutrients basically during the second trimester as an RCT. So either the broad spectrum micronutrients or you got randomized to the placebo with iodine in it because iodine is the only nutrient that's required or recommended by the Ministry of Health in New Zealand. So we didn't want to deprive anybody of what's been on offer. They were allowed to take any nutrients that their doctor recommended during that time if they were low in iron, then if you didn't matter what group you were in and that was recommended, we didn't stop that kind of typical prescribing from occurring. Because again, it's there's you've got one shot at this, and we certainly didn't want to impact on that pregnancy and the outcomes. So, um, 12 weeks essentially during trimester 2, although some started a bit later, and so they went into the third trimester. And then it was an open label study. So after they did the 12 weeks RCT, everyone was offered the micronutrients for the duration, the remainder of their pregnancy.
So just for those who don't know, RCT, randomized controlled
Yeah.
trials, we've got 3 months in. There's a 12-week
Yes.
period where
Yep.
some are on placebo and some are on a multi-nutrient, which we'll talk about.
Correct.
Vitamin
Yes.
and minerals, not omega-3s.
Yes.
We'll cover that
Correct. Yes.
and
I wish we had done that, but
that-
anyway, can't do
so
everything.
12-week effect.
Yes.
Continue. Yeah.
Correct. Okay. Yes. Beautifully summarized. So the first part is the RCT. That's the controlled part. And during that time, what we learned was that there's great news in all of this. Both groups did really well in terms of remission on depression scores. Um, and that's not in a way surprising. There's the Hawthorne effect, which is where you're being observed and you respond positively to the experiment. Um, there's a lot of care that went into those women. They're being monitored all the way through that 12-week period. Lovely graduate students who are meeting with them, interested in their how they're going. All of those factors play a huge role in outcome. So the good news is that just that care has such a positive impact. And so that's a good news story in the sense that if there are women who are reluctant to take antidepressants, then making sure that they're well looked after during pregnancy can have a really positive effect on their mood. But when we looked at the women more globally, that's when there were group differences. And that's something we find with the nutrient approach in general, is that it's not about any specific symptom necessarily that we're being targeted, but it's like there's like this tune-up, metabolic tune-up that happens that means that their sleep gets better. They're regulating their emotions better. Um, they're better able to cope with the stressors of life because they've got an adequate supply of nutrients for, the stress response. So they're just overall holistically better. And that is picked up on a measure that we use, which is the clinical global impression, which is looking at the mother holistically. And then the women themselves looked at themselves holistically and said, "Do I feel like I'm getting better?" And that's where we ended up seeing that there were about 69% who were identifying themselves as being much to very much improved, and the placebo group was around 39%. So you can see the placebo effect was large, but the effect of the micronutrients was much greater. So all in all, you could, the critics will say, well, it didn't treat the depression, but I would say, well, 75% of our women went into remission. So hard to argue with the strong effect of what I would just even call like a light touch therapy,
Mhm.
but holistically they were doing much better. So that's the RCT phase. We also did some biomarkers that I'm sure you're interested in. Um, and one of them there was the homocysteine. And
Uh,
I wanted to pull up those data. Did you want to go there?
yeah, let's go there.
Yeah, okay. So just understand that the number of people who were the number of women where we could get blood work was reduced because of COVID. So, but regardless, we still had a significant effect on homocysteine levels. And just trying to pull up the exact numbers because I figured you might actually want to talk about the exact numbers. Would that be right?
Yeah, and we're talking here about
Around
the women who are on multi-nutrients or the women on placebo.
Exactly. Yeah,
Well,
we're talking about both of them. So
yeah.
we measured homocysteine in both of those groups, and there was a reduction in homocysteine, a significant reduction of homocysteine in the women who took the micronutrients, and there was no change in the group where they took the placebo.
Mhm.
So that was a beautiful effect to see and it was a strong effect. The effect size on that one was 1.16 in
Yeah,
terms of the group difference.
yeah,
So it was a
what were
really
the
strong
kind of
effect.
homocysteine numbers? I'm very interested in that. There was,
Yes, I thought you would be.
yeah.
So, in the micronutrient group, it's done in micromoles per liter, so it's 4.43, and then it drops down to about 4. So they're not starting with really elevated homocysteine levels anyway. Um, so you have a drop of about a half
Yeah,
there.
yeah.
So, um, and then when it comes to the other group, there was no change in the active group. In fact, the other group went up. um, from 4.3 up to about 4.8. So interestingly, we noticed this with this sort of overall picture, which is that the placebo group, when it came to even the nutrient levels that we measured, they tended to drop, but in the case of homocysteine, going up is bad. They tended to drop, but in the micronutrient group, they held their own,
Mhm.
which kind of tells me that you need those additional nutrients during pregnancy for the mother to continue to be in a place where she is got adequate nutrients to
Mhm.
serve herself rather than serving the baby. So we looked at vitamin C levels, and there were far more dropping into deficiency in vitamin C. We did a whole paper on vitamin C if you wanted to have a look at that. I wasn't the first author in that, but there is a vitamin C study I can send you. Um, but the women were more likely to drop into deficiency if they were on the placebo than if they were on the nutrients.
Mhm.
We've done B12 levels across all of our studies outside of pregnancy, and we always see a really massive increase in B12 levels. But
Mhm.
in the pregnancy study, we didn't. We saw a little bit, tiny bit of going up, and we give a lot of B12 for these studies,
Mhm.
and a lot more than I think anybody's ever given in B12. And yet they were pretty much holding it, going up a little bit, but what was happening to the placebo group was the drop. And so that's partially explaining why there was such a big group difference. It was not that there was necessarily this massive effect on the pregnancy. But we were helping women hold it rather than
Well, that
deficiency
those
occurring.
kind of homocysteine levels, because we get, I mean, the clearest study showed that if a woman has a homocysteine above 9,
Yeah.
interestingly, their child at the age of 6 has a much greater risk of all sorts of problems, anxiety, depression, social problems, and so on. So levels in the 4 range suggest that nobody
Yeah.
here was severely malnourished.
Yeah.
You know,
We
these were,
I have to go back to the data, but the range was 5 to 15, which does indicate that there were some who were
yeah,
elevated.
yeah,
So I'd have to take a bit of time to look at what happened specifically to those women and
yeah.
whether or not their drops were much higher.
Yeah,
Um,
that subgroup stuff is really
yeah, it is. But with only 25 per group, you end up being in a bit of it challenged
small. And
with
some of the,
those.
and could you do any comparison of multi-nutrients and those on antidepressants? Because some women
Yeah.
in the study will have been on antidepressants.
Okay, so the Nutrimum study, in order to get into the Nutrimum study, you could not be taking antidepressants alongside the nutrients. So all women who were on antidepressants were excluded from the RCT.
Right.
The reason for that is the observations that have been made that if you take antidepressants alongside these doses, you tend to get worse unless the antidepressant dose is decreased.
Mm.
So you don't you can imagine in a blinded trial, the last thing you want to be doing is being also dealing with potential interactions between an antidepressant and the micronutrients. So all of my studies have been done with people who are off medications. That doesn't mean they've never been on them. It's just for the purpose of the study, they couldn't be on them. And of course, just to let you know, we never encouraged anyone to come off of their medications.
Mm.
The women made those decisions themselves. So, but consequently, what we wanted to, when it came to again, I'll just tell you the story because that's useful to understand the context. When we started this study, I thought we would get tons of women wanting to be in this study. And I thought uh, we would get prescribers wanting to send them to us because of all the what I thought were known risks associated or some, potential risks of the antidepressants. But in fact, what they were telling women was that these nutrients were dangerous and that they shouldn't take the nutrients. So we ended up I understood really early on that in order to convince the public once we studied these that when once the study came out and if it was positive, we needed to collect a lot of safety data. So that's where the extension of this study happened is that I thought, well, we then, because we know the antidepressants, there's some potential effects on preterm birth. We need to start looking at birth outcomes for these women. We need to set up a study that looks at those infants to make sure that we didn't harm them. And that's what happened. That's why subsequent studies were done within the context of Nutrimum. So in order to contextualize the outcomes, we needed to recruit mums who were not taking these broad spectrum nutrients at these high doses, um, and follow them and see what happened to their offspring and their birth outcomes. So we ended up with two other groups. One of them was a group of women who we call a reference group. They weren't, they went in and out of maybe mild depression, but in the overall context, they were a typical pregnancy. Well, I don't know if anything's typical, but they were generally functioning well, and they weren't taking a high dose of micronutrients, and they weren't taking antidepressants. Then we had another group, which was smaller, which was 20 women who were taking antidepressants during their pregnancy. So they served as like what I called standard care as a comparison. So if we could, that's often what you do. If you have a new treatment, you want to compare it to the current treatment to see whether or not it's better or worse. We couldn't do that because of the nature of the study. But what we could do is look at the birth outcomes and say, how are our birth outcomes compared to standard care? So that was what that's how Nutrimum got extended. Does that make sense?
That
Because
makes
it's
sense.
complicated.
Yeah.
So
No.
you've got the RCT, and then you've got two other groups that are getting recruited, not randomized, just serving as contextualizing our outcomes for our Nutrimums because there was so much concern around the risk of the nutrients
Yeah. So three groups. You've got the kind of
in the
no
end.
treatment. What's their outcome? You've got
Yeah,
those who are on antidepressants, and you've
yeah,
got those in your group who've got
yes,
multi-nutrients. So what were the effects on preterms?
yes. Yes. Okay. So, and just
Premature
also, and
birth.
just a little final clarification is that remember I said that after the RCT, all women went into open label, so everyone got exposure to the micronutrients,
Yeah.
unless unless they came into the study, say for example, they came in at 24 weeks, they came in late because our recruitment was 12 to 24 weeks. If they came in at 24 weeks, they were randomized to placebo. They gave birth at 36 weeks. They never got any exposure to the micronutrients.
Mhm.
So what we did was we selected only those women who had at least 2 months of exposure of the micronutrients during pregnancy,
Mhm.
although that could range from 2 to 6 months. This
Mhm.
is not the perfect study. We would need to do it again, to have everybody taking the micronutrients at the same time, but it did mean that we could also look at a dose effect.
Yeah.
The longer you took it, were the outcomes better? So just understand that piece of it. So it's not perfect. If I could do it right, I would do it again, but I don't know if I will ever do this again. So it's been 10 years of my life. So we looked at the birth outcomes. And so the good news story here for the micronutrients is that on every variable that we looked at, there was nothing there that suggested we were causing any harm. And that's when you look at APGAR scores, or you look at NICU emissions, or you look at neonatal intensive care emissions, or you look at birth weight or birth length, hemorrhaging, everything that we looked at, those micronutrient exposed infants were doing as well as that reference group or better. And they were better than all of our national norms.
Mhm.
So, for example, if you look at preterm birth rates in New Zealand are 7.9%, and our rate in our micronutrient exposed kids was 5.5%. In
Mhm.
the reference group, there were no preterm births. That's just how it went. But then that's maybe not surprising. In the antidepressant group, the preterm birth was 20%. So you could argue that particular sample was small, but when I looked at the rates, when I was saying earlier that the preterm birth still does happen at a higher rate in moms who take antidepressants in pregnancy, what I found was that it ranges between 15 to 24% preterm birth in moms who take antidepressants.
Mhm.
So, but if you're depressed, your risk of preterm birth is around 15%. So what I'd like to see as the positive story here is that we mitigated the risk that depression causes on preterm birth. Does that
Mhm.
make sense?
Yeah, no,
Yeah,
that makes
whereas antidepressants aren't
yeah.
doing that.
Good.
So postpartum hemorrhaging was actually significantly lower in the infants who were exposed to the micronutrients. I'm just trying to get those numbers specifically
Oh.
uh, for you. It was just under 15%. Oh, sorry, postpartum hemorrhaging was about 8% in the micronutrients babies, whereas it was around 30% for the reference group, and it was around 26% for the antidepressant
Mm.
exposed kids. So that's, some suggestions are it's the vitamin K that's within the formula. We don't know why that happened, and it wasn't something we were necessarily expecting, but
Mhm.
it's again a good news story if you can reduce postpartum hemorrhaging. Resuscitation
Mm.
was much lower in our micronutrient
Mm.
exposed kids. So all in all, they were higher birth weight.
Yeah.
They were longer than
Yeah.
the standard care. Their gestation was 1 week longer. They were taller. They were 2 centimeters taller, and they were about 300 grams heavier than standard care. So all of those things we know are good outcomes, good indicators of a good start to life.
That's excellent. So good news for the mother, good news for the baby.
I know.
Did you look at the baby's temperament? Is there any other measures that are worth
We did,
reporting?
we did, and so that was something we thought, why don't we look to see what happens to these infants before, all these other environmental things can influence them. So you can do a measure of is it temperament? I mean, a lot of people will argue about that, but there's a measure that's called the Brazelton Neonatal Behavioral Assessment Scale that you can do within 4 weeks of life. And so we did that with these three different groups. And what the Brazelton looks at is things like how well do they habituate to their environment? Can they orient themselves? Can they follow and track something that's being shown from one side of their visual field to the other? How do they react to surprises in their environment or to noises in their environment? What's their motor control like? Can they sit up easily? How are their reflexes? So looking at those, early reflexes, are they standard? Are they normal? Or are there abnormal reflexes? So we were able to look at all of those within the context of these different groups. And again, remember what we're looking for is just to make sure we haven't caused any risk or there's no early indicator of a risk to these kids, which I think you might think is probably ironic because we're giving them good nutrition. So that there shouldn't be, but that was the context we were doing the study in. And in every single thing that we looked at, whether it was habituation, autonomic stability, motor control, orientation, regulation of state, or the reflexes, in all of those, the micronutrient babies outperformed um, the standard care, and the effect sizes between them were really large, like 1 to 1.5, so really significant group differences. But in some areas, those kids were also outperforming that reference group, those of the typical kids. So we ended up with what we called the super babies, because the mothers would describe them as being they were just so different from their, if they'd had another child before. They just really thoughtful and really interested in their environment and just really calm and capable. And those were things that we heard about early on, and we're now following those kids. They're now turning 5, and we are in the process of looking at what's happening to those kids at 5. It's not a perfect, in any stretch of the imagination, of a longitudinal study. It's kind of turned into that, but there's, as you can hear, the scientist is very much
Well,
recognizing a lot of limitations of the
yeah,
study.
and you're saying healthier, happier mothers, healthier, happier babies, better
Yeah,
outcomes. It's all good news.
it
Before we
is
look
all
at
good news.
Yeah, before we look at the what are these micronutrients, you said one thing that sort of appears contradictory, which I actually have never heard of before, which was there was a reason why they couldn't be on antidepressants and micronutrients.
Mhm,
You said that there might be some suggestion or evidence that the combination can make a person
mhm.
worse.
Yeah,
Could you unpick that a little bit? That's new to me.
sure. Okay, all right. So, this was something that was observed really, really early on by those families, that a lot of people who were trying the micronutrients were on medications. And so they didn't assume, they assumed that it'd be fine. And what they found was that about 2 weeks in, while they were getting better, then suddenly there was a regression. And so what was happening? And the way, so Charlie Popper's a psychiatrist at Harvard who was interested in all of this work really early on. And he started to use the nutrients in his own practice. And what he thought was happening was that there was some kind of a potentiation happening of those medications. So the micronutrients, are they, if you think about what the antidepressant does, it influences the serotonergic system. When you think about what the nutrients are doing, they are impacting on the development and production of neurotransmitters. They're providing those cofactors. So it does make sense to me that if you've got both things happening at the same time, you're going to end up with potentially some kind of a serotonergic syndrome happening, and you're going to get these people are over medicated. And so what the psychiatrists who use these in practice do is over time they cross taper and they reduce the medication down. It's very counterintuitive for a prescriber to do that, because when someone gets unwell, they've been on a medication and they start to get unwell, their response is to increase the dose of the medication. But if you do that with the micronutrients, they get even worse. And so that's one of the things that's being clear from the get-go, and the one thing that I make very clear when people contact me about the nutrients is that if they're on medications, they need to talk to their prescriber about cross tapering. And the prescriber needs to understand how to do that, because some medications, of course, as you probably know, or I'm sure you know, are hard to come off of. And so you're not only grappling with this potentiation, but
Mm.
if they start to reduce, you end up also grappling with withdrawal. So it's a difficult thing to navigate, and hard for the patient at the end of the day. So yeah, that's something that's been observed. We've published on this as well. We've published showing that the outcomes are better if people do this cross tapering than if they don't. But you can imagine it's impossible to do a controlled trial in this kind of
Mm.
space. Yeah.
Okay.
So yeah, no, and that's is it, and it's probably because the doses are so much higher than your typical multivitamin that you get at a supermarket. So you wouldn't get this kind of effect with a super low dose. But as those doses are up in the levels of that we've been studying,
Yeah.
then this effect has been observed, and it needs to be taken really seriously. Otherwise, the person gets really unwell. I
Okay.
know it just so if you've never heard that, now do you reflect on people who may not respond to high doses, or
Well, it's interesting because I was reading a recent pharmacology study which argues exactly the opposite. And
mm,
so, in a sense, if we're looking at serotonin, which is said to improve your mood, and what a serotonin reuptake inhibitor is doing is blocking the receptor, so you should get more serotonin in the gap. Then the
yes,
fear was that if you promoted the production of serotonin, which certain nutrients will do, then you could possibly get too much serotonin, which is a dangerous thing.
yeah,
Now, the nutrient that most does that, I mean, the nutrient that is the precursor for serotonin is tryptophan, and specifically 5-hydroxytryptophan.
hmm,
So in this recent study, it was not that recent actually, but it's a very good review of all studies. And also in my own work, because you won't know that I was the person who brought 5-HTP into the UK.
yeah. But there's no
Um,
5-HTP in the
I
supplement.
get that. There's no 5-HTP, but it's like if there was a nutrient culprit that could exacerbate or impact the effect of depression, it would be 5-HTP. And
Mm,
what it appeared is there is actually no case of serotonin syndrome having been induced by the combination of 5-HTP and an SSRI. And there are actually a number of studies that show that the combination improves the effectiveness of the antidepressants. So this particular review is proposing to upgrade antidepressants by the inclusion of 5-HTP, right?
Yes.
Which is
Okay. Well,
kind of
and
an
that may
opposite
well,
effect. Yeah, it's kind of an
yeah,
opposite,
well,
but so it's interesting.
but is there
Yeah,
a limiting factor in that if you have 5-HTP, in order to convert 5-HTP to serotonin, what do you need? You need cofactors.
yeah, indeed.
So if those cofactors aren't being provided, then maybe it's limited. Is it being self-limited?
Well, maybe it's a very strange thing
Mm.
because I mean, I'll tell you the story. This is quite good fun because when I worked out that 5-HTP was the precursor of serotonin, I went to the Professor Henry, who was the UK government's chief toxicologist, dealing with things like overdoses of MDMA, ecstasy, et cetera, et cetera. And I was just concerned before I wrote anything about 5-HTP that, potentially you could get a serotonin syndrome, you could harm someone, kill someone. I was concerned. So I went to him and he said, there is absolutely no way. The brain has so many checks and balances. There's no way that 5-HTP could cause a serotonin syndrome, but an antidepressant could. Do not think that they are
Mhm.
harmless. That was his view. And I did it,
Yeah.
ask him about ecstasy, MDMA, and he said it's not really harmful. The problem, if it's pure MDMA, is that some people dehydrate. They dance like bellends and don't drink enough water.
Right.
And then we
Right.
had a terrible case of a girl, Leah Betts, who was so paranoid that she would dehydrate that she overhydrated and literally died of drinking too much water. So
Oh dear.
so he kind of gave the thumbs up for 5-HTP. And since then, because it was really pioneered by the Japanese, and I've just come back from Japan, we have about 30 randomized controlled trials on 5-HTP, which, using a usual scale for depression, the Hamilton rating scale, which have outperformed the SSRIs. And some of them are comparisons, fluoxetine versus
Hmm.
5-HTP. So I became more and more confident about that. And then the psychiatrists that I work with who help people withdraw from antidepressants, which is very difficult, and even more difficult with this new generation of Effexor, Cymbalta, duloxetine, the serotonin and noradrenaline reuptake inhibitors. What really makes the withdrawal from those drugs, which can be horrendous, workable, is to start to take nutrients like tryptophan, 5-HTP, magnesium, B vitamin, zinc, phasing one in and phasing the other one out.
Hmm.
So but I hadn't heard.
That's the cross tapering.
Yeah, it's a cross tape.
Phasing one in, phasing one out.
Yeah,
Yeah.
yeah, yeah,
That's exactly what they do and
yeah,
recommend you do
yeah.
with taking the nutrients. But
Well,
yeah, no, well, I don't, I need to look at those data around why it is that you get the opposite effect with just giving
yeah.
5-HTP.
Well,
Interesting.
we'll swap studies.
But the other thing is that that we don't know the mechanism. One of the things that we have looked at, and we're trying to publish this right now, is whether or not there's any impact on the CYP enzymes
Mhm.
that are the ones that metabolize in your liver metabolize antidepressants, and whether or not the micronutrients are impacting on the CYP enzymes. We don't think that's what's happening, and we're in the process of just publishing those specific data, which is why I jumped to the other potential hypothesis, which is that there's an impact on the serotonergic system, or just an upregulation generally
Well,
of.
let's swap papers and keep talking.
Yeah, so no, and it's interesting. But anyway, that's why from the
Yeah,
get-go. But also I'm not a physician. So
yeah,
um I wouldn't want to deal with the medication. I can't deal with the medication issues during our trial, but it's been really it,
yeah.
makes it easier to interpret the data because we don't have some on medications and some not. They're all off of it.
Mhm.
Um they're all chosen to not either not take them, or to they've chosen independently to come off of them to be
Now
in the study.
okay, let's go down into the micronutrients that were given in your study,
Yes,
because the levels of them are remarkably different to RDA. I'll give you a few examples. Like
correct.
zinc, the RDA is 11 milligram.
Mm,
The
yep.
supplement you were using is 48 milligrams, so it's more than 4 times higher. Vitamin D,
Mhm.
the recommended intake is laughably 200 international units. You were giving 3,000 international units. B12, the recommendation is 2.6 micrograms. This
Mhm.
supplement was 900 micrograms. So how did this supplement come into existence, first of all, just so
Yeah.
we understand?
Exactly, exactly. So I'm not here to defend the nutrient levels or even be able to explain why the nutrients are what they are. I'm just a scientist who had curiosity and decided to study it. So um, you better to talk to the manufacturers. But I can say a few things, and that is that um, the RDA concept is out of date. It's so out of date. It's crazy that we're still even using it and that it's still on food packaging. It's a concept that my understanding was developed around World War II to make sure that troops were well nourished to fight, um, and to have, to influence and have make sure that they have the nutrients to not have any heart issues or they're, to make sure that um, they yeah, they could survive in certain conditions and not get scurvy, but they weren't developed with the brain in mind. And David Benton has written, I remember him coming out with a review, it was about maybe 10 years ago now, that challenged I think it was, he must have gone through and challenged pretty much every single one of those nutrients in the RDA and saying that they're just not adequate around what the brain needs. And so I suppose what I'd prefer us to do is get somebody to defend the RDA rather than to defend the nutrients that are used here. Like if you were to have consume, say, 5 oysters, how much zinc would you consume?
Mhm.
You'd probably be consuming around that amount of zinc if
Probably
you were
about
to.
50 milligrams
Mhm.
of zinc. Yes, absolutely. It would
Yeah, yeah.
be
So
level.
so if you take it from a food perspective, it wouldn't. I mean, the selenium levels, you'd need 5 or 6 Brazil nuts to get those selenium levels. So it's not, um, they're not outrageously high doses, but they are when you compare them to RDA. Now, B12, there is no safety issue to do with B12
Mhm.
at any level. And why the B12 level is so low with RDA, I mean, all of us question that one. And all of us wish that that would get sorted, but nobody in government really seems to care that
Well, I
these
think
levels are so low.
I'm not concerned about the high levels. They're very, very close to what I would recommend, having looked at all
Oh,
this.
is that right?
Yes,
Okay.
I don't have a concern about the high levels. I'm just very interested because the
Yes.
and if I explore some of these, I'll give you an example of vitamin A. Because
Yes.
actually, the relevant point is to look at 99.9% of humanity's history and evolution and what we did eat. And if you are aware, I know you are, but if people really absorb the context that we could not have developed a big brain without a significant amount of marine food. In other words, we were
Mhm.
living along the water's edge. When you say 5 oysters, people are thinking, God, that's like for rich people, champagne, caviar, oysters. But actually, it's very, very likely that women, particularly, the men might have gone hunting, but the women were gathering, and the place on the water's edge, and the rivers, and the estuaries, and the coasts,
Mm,
and, you know,
you would eat a lot.
you need a lot, and
Yep.
and then the same thing occurs with vitamin A because our ancestors were estimated to be getting about 10,000 micrograms of retinol. Your
Wow. Right.
pregnant women are advised to have only 300 micrograms of retinol. The
Yeah.
upper safety level is 3,000 micrograms of retinol, which I don't think is correct.
Yes.
And the
Yes. And then
supplement,
we're giving that amount. Yes, I know, much
you're
higher.
giving about 1,700, 1,800 micrograms. And funny
Exactly.
enough,
And
yeah, and the story there is a weird one because what actually happened was that vitamin A is so effective for acne, but
mhm.
unpatentable, that Roche developed a drug, isotretinoin or Roaccutane. And what happened is some women were giving birth to children with birth defects, and it really focused on this. And they discovered that this trans-retinoic acid, messed up but patentable version of vitamin A, was actually teratogenic. And that created this fear of vitamin
Fear.
A. But I still do not know of a single case of a woman who has had that type of birth defect from vitamin A, retinol, natural vitamin A. However,
Exactly.
and the funny thing you say is you couldn't find a single study on antidepressants in pregnancy. Virtually every supplement has to say, do not take,
Don't.
don't take in
I
pregnancy
know.
breastfeeding. And if you ask why, they say, well, they haven't done a study on it because actually it's
I
quite
know.
hard to get to
Exactly.
ethics to do a study
I
on,
know.
you
I
know,
know. Well, that is the irony for all of this. But
yeah,
the vitamin A was the reason why we didn't even consider
yeah,
doing this study during the first trimester, is
right.
that we didn't think we would get it through
Mhm.
ethics
Yeah,
to do the research. So we didn't even touch it. Is there a concern about taking this in trimester one? Logically, no, but you can imagine because of the whole story of vitamin A and the fear around it causing congenital defects, there there was no way we could justify we
yeah,
could get it through. But when you're asking me to why are the levels so high? What I'm usually asked about, and which I'm far more familiar with being able to answer this, is are they safe? And
yes,
so I've had to go through every single one of those nutrients and provided to our equivalent of FDA, which is MedSafe. I had to go through all of the 36 or so ingredients and give toxicity information about all of them and say, we've looked at all of these nutrients individually, and there is nothing to indicate that those doses are
no.
unsafe. And so, therefore, they granted us permission to do the study. Whereas the question you're asking is, well, why did they go so high? And you'd have
Oh,
to ask the developers of that about why they did that. But it sounds like I mean,
well,
they did their research. They
I
looked
like
at
the
what,
way they're thinking. I like the way they're thinking. And the funny thing I mean, I've written whatever it is, 48 books,
hmm,
30 languages. Millions of people have followed my fairly, you know, pioneering, high dose
yes,
approaches. And I've been instrumental in training, many, many thousands of nutritional therapists. And my insurance, my health insurance, is actually £50 a year. Well, I used to think it was £50 a year. I get £2 million cover. So in other words, if I recommend 5-HTP to you and you suffer, and you sue me, I've got £2 million cover. But actually,
wow,
even £50. It turns out now, under full disclosure, that £25 of that is admin and profit. So my
okay,
insurance for a £2 million cover is £25, which is purely based on the safety. In other words, these things are very safe. And then chromium,
yeah,
I'll mention two other nutrients because chromium,
go for it.
it was funny because I was at a conference not so long ago where a lot of GPs are switching on to low carb.
Yeah,
As you know, they're kind of no pills. They just want to get everyone on low carb for everything, sometimes a bit keto. And they were saying, we want what we need a randomized controlled trials showing an effect on the best long-term measure of blood sugar, HbA1c.
mm,
And I remember at this time, a couple of years ago, I stood up and said, well, what about chromium? There's 29
mm,
randomized controlled trials on chromium at a dose of around 600 microgram, which is exactly what you gave,
yeah,
showing a significant reduction in HbA1c blood sugar, stability. It's actually the HbA1c is the damage that occurs to red blood cells from sugar. So we're saying significant less damage to blood cells with 600 microgram, but you do not see that effect with 100 microgram. There is
hmm,
no RDA, but the broadest recommendation is 30 microgram. So again,
hmm,
this supplement
I
is
know.
is not 10, but 20 times higher.
Yeah.
And the safety data is absolutely fine. So the one thing out of your work that if the broad line is micronutrients mean healthy women, healthy babies, and people go off and take an RDA multivitamin,
It won't get the effect.
they won't get the effect. Yeah,
I don't think so. Yeah.
no,
I mean, I can't say it confidently because the placebo control trial hasn't been done.
yeah.
But know that the reference group,
Mhm.
we're allowed to take vitamins and minerals during their pregnancy. So they were taking what would be a prenatal, those prenatal supplements like Elevit or that kind of thing. So we couldn't obviously stop them from taking nutrients that they wanted to take.
Yeah.
And yet the micronutrient babies outperformed even that reference group when they should have been on the back foot, because remember, they had the depression risk
Yeah.
because they came into their pregnancy depressed. And then they entered a study to the Nutrimum study, but they had to be depressed to get into the study. So they were starting off with much higher risk factors, and yet not only did we mitigate those risk factors, but in fact, on some measures, they were better than these moms who were just taking a standard multi.
Now, this conversation is very much about a combination of nutrients as opposed to a single nutrient, and also moving towards the dose. This study cannot define what the optimum dose is, but at least it, feeds into that conversation. And it's very much like, in 1987 when we did the study with David Benton, Willem Roberts, and I was kind of behind the scenes on that. I designed it. To a large extent, then kind of got out the way, and I did the diet analyses. And what happened was we got a result, a very, very good result. And I remember a professor of psychiatry coming to me and saying, it's a useless study. And I said, why? He said, because you don't know if it was the vitamin B, the C, the
Yeah,
A, the D. You don't know what it was that did it.
yeah,
And
yeah.
the funny thing is that since then, and literally because of that study, there have been studies which gave RDA multis and didn't work. There have been
Yep.
studies given almost every single individual nutrient hasn't worked. I think B2 riboflavin, there was one study that got an effect on just that nutrient. And in hindsight, I would say, what, if I had to guess, I don't know, what probably was what was working in this? And I
Yeah,
would
yeah.
probably go for the methylation nutrients. And we're talking about B6,
Mm.
B12, folate, all of which are very high in this formula, and zinc, which is very
Hmm.
important in methylation. And these are the ones that lower the homocysteine. These are the ones that are very strongly connected with the cognitive function and so on. We don't know that. So it was interesting to see your homocysteine, data in that respect.
Yeah.
Um,
Yeah, and I can't argue for or against whether or not it's necessary to have all of those other minerals and vitamins in there. But I guess what I always go to when people do say, well, which is the nutrient that's effective? I'd say, well, if you look at and this is something that I have upskilled on over the last decade or so, is if we look at the our biology, and we look at all the different things that are happening in our body, whether or not that's the manufacture of neurotransmitters, and we look at those pathways, metabolic pathways, or we look at the manufacture of ATP, and we look at the Krebs cycle. Or if you look at, you could look at the methylation cycle and what nutrients are required for the methylation cycle. Or if you look at detoxification pathways, when you start to look at it from that perspective, you kind of go, but all of the nutrients are required for all of those different processes. So is it would we get the same effects if it was just the ones involved in methylation? I'd say, well, what about ATP manufacture? Don't
yes.
you need a whole bunch of different minerals and vitamins for that, that aren't just the ones that are involved in methylation. So that's where I would argue this idea to ask the question of which one is it
Mhm.
doesn't take into account then our physiology and what the body has evolved to need, which is a broad spectrum of nutrients and a broad spectrum of colors and foods, and
Yeah.
that we need all of these different nutrients.
Yeah.
So would we get the same effects if we took some of them out?
Mm.
I don't know, but to do that would require another lifetime of
Yeah.
studies,
No,
which I
fair
guess
point.
I'm just not prepared to do.
But have you done
There's
any
only so
studies
far.
on children and teenagers and multi?
Yes. Yeah, we have done that. Do you want me to just say that? I mean, the one thing is that there's no omega-3,
Yeah.
there's no EPA and DHA.
Yeah.
And it's something that over the years has always been something that has been suggested that why don't you add in EPA, DHA? Now, if you were to do that, they would need to be a separate pill,
Mhm.
right?
Yes.
And I think what where I end up going is, but if it's a separate pill, then why don't we do something like, I think even I feel like David Benton's done this, or somebody has done this, where they've done the multi-nutrient plus the omega-3 without the omega-3 on their own, and then placebo. So you'd end up with a four-arm trial, and that's often what I kind of think I should do, is if I were to do that, I do a four-arm trial, and then it ends up being the numbers are just too high around recruitment and the amount of money I would need to run that kind of study, that we've just never gone down that route. So it's not that I don't think it's important. It's just that you'd always need to give it as another pill,
Mhm.
and that's kind of that's just been the challenge I've come across, and just to come to the decision of that kind of study is just too complicated for me. But it doesn't mean that I don't think they're important.
No,
So
especially now that we're seeing
so I appreciate that. Yeah.
and the
Yeah. So
synergy has just been shown in now 5 or 6 studies of
exactly.
B vitamins and omega-3 means that even the studies on omega-3 may be, quite underestimated. But anyway,
Yeah.
we'll
So
park we'll park that
yeah,
one.
so maybe
Yeah. Yeah.
I'm getting tired of doing RCTs.
Yeah.
Um, so could we do another one where we just added, also made sure that they got a decent dose of EPA DHA? That would be a
Yeah.
nice thing to do. So, or could we, as you say, improve our outcomes? Because not everyone does, responds to this effect.
Mhm.
So maybe that's the limiting factors, that we're not adding in the omega-3s as well. So
Yes.
yeah, that's for the future, Patrick. So it's not that I don't think it's important. It
Mm.
just hasn't been done yet.
And what about your
Um,
studies on children and
children.
teenagers? Yeah.
Yeah, sure. So, I mean, our studies started with adults because, again, going back to this whole safety issue, which is what predominates my thinking, or having of coming up with these studies, is that we have to defend the nutrients that we're giving. So we started with adults with ADHD because the ethics committee wouldn't allow us to do it with kids until we did a study with adults. So we started there. We saw benefits generally. I mean, in some variables, we didn't see group differences, but overall, the micronutrients outperformed the placebo in improving ADHD symptoms in adults. We then did a study with kids with ADHD and found that the effect, while there were some benefits on attention in particular, the effects were more on emotional dysregulation, which is often a co-occurring challenge of people who have ADHD, although it's not part of the diagnostic criteria. Some would argue it should be, but historically it got taken out of the criteria for ADHD many years ago. Think of the 1980s, if we go back in the DSM. So, but that's where the main effect is in emotional dysregulation. So we've ended up now doing a study with teenagers that we've just finished, and I'm working on analyses right now. So um, I don't want to talk about them more because we're still in that process of that analysis and trying to look at subgroups and things like that. But we're seeing the similar types of effects in the teenagers as we've seen in other studies. So I mean, overall, there's the takeaway is that it seems that when you see an effect, it's that you're seeing these global impacts on anger, aggression, temper, irritability. These symptoms that are what we call transdiagnostic. You see them in all different psychiatric disorders. And so the nutrients aren't something that's specific for any kind of disorder, although that's often how we've had to study it. But the effects seem to be more global. I mean, the studies that were done by Jim Adams in the United States, where he looked at the effects of micronutrients on autism, kids with autism, and looking at their functioning, again, he observed these kind of similar effects where there were benefits in that emotional regulation, receptive language, global impressions. Um, that's where the group differences really shone through.
So do you think your
So
study, will you have some results by the end of April where we're going to have a great big conference on nutrition for smart kids?
Oh, the teenagers, I could probably present them, because if it's a conference, I'm very happy to present on. It won't be published by April, but I should have the results by April, so I can share those with you.
Well, that will be fantastic. And we have another
Yeah.
assistant professor who's going to be revealing some rather extraordinary results of long-term results of treatment. We're not quite allowed to
Yeah.
use the word, with micronutrients in autism.
Right. Well,
And
really look forward to that.
yeah, and for those of you who don't know, and now you understand why, we have a phenomenal team of a growing team of well over a dozen world-leading professors who advise us at the charity Food for the Brain. And Julia, you can now understand, is one of those because of your fantastic and amazing science. And I've been well aware that you've been jumping up and down saying, when are we going to do some kids? We need to, dementia is what we've been kind of seemingly
Yeah.
focused on. And we need to do kids. So we're working very, very hard to release the program Cognition for Smart Kids in April.
Yeah.
Because the extraordinary thing is the very same test, the cognitive function test that is used to pick up early changes in cognition that would support or lead to a diagnosis of dementia. We're actually seeing that cognitive function decrease, certainly from the age of 18. And we're now using the very same test that is used, if in effect, to diagnose dementia on kids down to age 7. They're able to do it. And I think what you start to understand is that the randomized control trial model, reductionism, is fantastic if you have one thing you wish to test. It could be one nutrient or one one multi as well, but then the dose thing gets confusing. And versus placebo, and one thing you want to measure. And what we realize is that's just not how life is. There is this melange of factors, social, psychological, environmental, toxic, nutrients, anti-nutrients, and so on. So our dream, and we have now tested almost 500,000 people, and we're launching next year in China, and we hope to test in the millions. And in fact, what we hope is by the end of this year, the test will be in every language, certainly available in India, Japan, China, Arabic, French, Portuguese, German, Polish, probably Spanish. And we intend to get data on millions of people. And please understand that when you run a randomized controlled trial, and a really nicely designed one, like Julia is doing, which is very expensive and takes years of work and has all sorts of limitations, the only purpose of doing it is to then guide policy of what people do. So in other words, you want to roll it out to millions. If we're able to get data on millions, we can find out whether those who combine omega-3 and multivitamins or this with that, we can actually find out what are those combinations that are really working. So it's a big data approach. It's kind of top down rather than bottom up.
Exactly. Yeah, and you need both. And I mean, ideally, you have both.
Yeah.
Um, and I mean, even if we think about the nutrition space, I mean, we haven't talked about diet, but all of this starts with those observational studies that show that the more you're eating nutrient poor food, then the greater the likelihood of having mental health issues. Mom who eats poorly during pregnancy increases the chance that there's going to be more challenging birth outcomes. The child is going to be at risk of having more developmental challenges, et cetera, et cetera. So you take those big observational studies that show those dietary patterns are influencing. You do RCTs with diet. You look at people longitudinally over time. If I eat eat a good diet today, what impact will that have on my mental health in 5 years? There's those prospective studies. So it's collectively we need all of it, and then the RCTs as well. So they all come as a package. I think what's just been really unfortunate is that we've only focused on the RCTs, and that's why the medicine only focuses on the RCTs unless it's inconvenient for them. As I pointed out with pregnancy, where there are no RCTs, but that's always thrown at you, always from the beginning, is that there's no RCTs that show diet is relevant. I mean, and so I see my work as proof of concept, which is that the nutritional environment is inadequate, and we're giving nutrients at these doses that you could actually be able to source through your environment, like as you were describing, um, in hunter-gatherer days, you could get the nutrients at these doses. So it's not like they're in doses that are extraordinary that you could never get out of food.
Mm.
Um, but they are in doses that are much higher than what you'd get out of ultra-processed food.
And the last point I'll make, because you said, you could get this selenium for 6 Brazil nuts. I actually looked at the latest analysis of Brazil nuts, and there is a 40-fold variation in the selenium level in
Not
Brazil
surprised.
nuts, right?
Yeah.
So it's also the sheer fact that we don't really know through the process of food production what
Yeah.
we are actually getting. And the idea of supplementation is actually takes us much closer to what we would have been getting in that 99.9% of our sort of evolutionary history. And that kind of logic needs to be factored in as well.
I think so. And I think that needs to also be how it's understood, because oftentimes it's understood from the context that these doses are outrageously higher than what you'd ever get out of a diet. But I often use a illustration. Like our population has been so focused on RDA that when they almost see RDA as being like the danger level, that if you go above that, then you're starting to increase the likelihood of harm, which is wrong. But because it's so prevalent in the food packaging and the way supplements are sold to us, that we really do think that they're these gold standard of like the upper limit of what you should take. Um, I will often just give an example of, say, the kiwi fruit and how much vitamin C is in the kiwi fruit. And the kiwi fruit, which is one of the big things that New Zealand exports, that the vitamin C goes way above RDA, and yet we're not killing people overseas. So clearly it's okay to take things over the RDA. And then the audience will kind of go, "Oh yeah, I guess that's true." I can see that there's some flaws to the system. But the system is so entrenched in our vocabulary and our understanding and how we eat and how ultra processed foods are sold to us, that it's going to take a lot of undoing of a lot of wrong that has happened to us based on what the food industry has done and the supplement industry, and all kinds of um, misguidance of our population for a long period of time.
Well, thank you immensely for being part of the undoing army and for your brilliant research and your
Thank you.
commitment over decades and your tremendous support for our charitable
Oh,
endeavor.
I'm really excited about what's going to happen with smart kids and where that's going to go, and really excited to be part of this big data. You can see I'm being involved in the little data for a long time, and just like these very small studies trying to control variables, understand things, all of that. But I also appreciate the other end of it is also part of the big picture. We need that too.
Well, thank you so much for your time. It's been a fabulous conversation. And for those who are listening, do put the date of April the 24th in your diary because we're going to dive deeply into what you really need for smart kids. Thank you, Julia.
Thank you, Patrick, for having me.